Good afternoon and welcome to the Power to Heal webinar hosted by the California Poor People's Campaign, a national call for moral revival. My name is Rose Gudiel Escobar from the Inland Empire, and I serve as a co-chair of the California Poor People's Campaign. We are a national movement of people in 45 states coming together to confront the interlocking evils of systemic racism, poverty, ecological devastation, militarism, and the war economy, and the distorted moral narrative of religious nationalism. We understand that we need a movement that will shift the moral narrative, impact policies and elections at every level of government, and build lasting power for people and impacted people. This is why we are very excited you are here and look forward to your continued participation. Today, you will see a 30-minute version of a film, The Power to Heal. This film highlights the power of a moral fusion movement to bring systemic change, focusing on how the civil rights movement helped to win Medicare, which was then used as a vehicle to desegregate hospitals. Panelists following the screening will share experiences that illustrate why we need to end healthcare inequality, how we can take action, and as the PPC Jubilee platform states, we need quality healthcare for all today. And in the tradition of the Poor People's Campaign, a national call for moral revival, we, of course, will have singing and opening and closing of prayer. So thank you so much for being here with us today. I will now like to welcome Reverend Beth, another one of our Cali PPC co-chairs. She will do our opening prayer.
Thank you, Rose, and welcome to everyone. It is good to be together this afternoon. And although we can't see your faces, we see your names, we see that you are gathering, we are gathering from across this state because we know that our presence counts and bodies count. I would like to invite you to take a breath with me, to arrive from the various parts of your day, the various parts of your lives, and the various parts of ourselves. Pause in a time we recognize that how precious the breath is. This time of violence and death, we acknowledge all that is on our hearts and on our minds. We pray for those who are the victims of gun violence, police murder, and their families. So just let's hold that and acknowledge that that is also with us now. I invite you to be present to your body as it is in this time and this space. We are here, beloveds. We are here to name the need to heal this nation. We are here to claim the power to heal this nation. We are here to proclaim that the voices of the most vulnerable, the voices of the most neglected will be heard. We gather to amplify our voices, to proclaim that we will heal this nation, to end the inequities in healthcare. We gather from the various parts of our days and lives, present to all that is, present to one another. We will end these pernicious death-dealing policies. May the time that we are together nurture and nourish our bodies and our spirits, enliven us, equip us, motivate us to do this work that love calls us to do, that the Holy One who moves in, through, and among us calls us to do, and empowers us to do. It is good, beloveds, to be together. Amen.
Hi, everyone. My name is Jim Pugh. I'm a member of the California Poor People's Campaign Steering Committee based in Ohlone, Oakland. Just a few housekeeping notes for this event. You have a couple of ways to be engaging with us as we go through. If you have questions for the speakers or during the video, you can post those using the Q&A function. You'll see a button for that near the bottom of your screen. You can type your questions in there. But there's also, you're welcome to post in the chat, letting folks know where you're joining from. And also, one of the things that we want you to be thinking about throughout this program is the question, what would healthcare for all mean for you? And we're going to have some time at the end for you to be able to share that, but be thinking throughout. And if you have thoughts on that throughout the program, feel free to be putting that into the chat as we go. Thank you.
Hi, everyone. I want to again extend a welcome for you all for being here for this important event. My name is Jenna Kyle, and I will be your MC for this presentation. I am an active member of the Los Angeles Poor People's Campaign and a member of the Policy and Education Working Group. We are blessed and honored to have an artist with us today, Arne Batson. Arne is a Los Angeles-based singer, songwriter, and vocal activist. She additionally serves as artistic director for the Voices Raised LA Vocal Collective, a grassroots a cappella ensemble that performs historic and original songs advocating social and environmental justice.
Greetings, neighbors. I'm Arne Batson of the Sing Network. I am so grateful to be here with you this afternoon to share an optimistic reminder that we do possess the power to achieve justice for healing in every aspect of our lives. Dr. King said, "Power at its best is love implementing the demands of justice. Justice at its best is power correcting everything that stands against love." That was true then, it's true now. Let's continue standing together, keeping justice as our collective goal, and let our healing begin within. The song is Justice. Sing along with me. Justice, 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 justice. Oh, let it be so. Justice, sing for justice, 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 justice. No, let it be so, let it be so. Justice, justice, justice. To cleanse the soul, justice to make us whole. Let it be so, justice. Let there be justice. Justice must overflow. Justice where it is owed. Let it be so, justice. Sing with me, y'all. Justice, 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 justice. Oh, let it be so, justice. Stand for justice, justice, justice. Shout for justice, justice. Pray for justice. Let it be so. Oh, justice. Fight for justice. Stand for justice. Be about justice.
Amen. Let us be about justice. Thank you so much, Arne, for that beautiful song, beautiful reminder. I would just like to take a moment now to introduce our California co-chairs for Poor People's Campaign. Our first co-chair is Rose Guidel Escobar. Next, we have Faye Wilson Kennedy. Following is Reverend Dr. Beth Johnson. Our national rep is Kate Ziegler, and our national steering committee member is Kenya Alcocer. And we want to remind you there should be a survey in the chat soon. If you're interested in joining a PPC working group, we would love to have you. We should now have an introduction to the film, actually, from Margaret Prescott.
All righty, thank you. Thank you so much, Jenna. And I'd like to remind the tech team, Patrick and others, to turn off your video. Am I spotlighted here? Okay, well, I'll just go ahead and talk about the film. This is Margaret Prescott, and I'm really thrilled to be able to welcome you to this screening. In addition to the work I do for the Poor People's Campaign and with the Global Women's Strike, which is a partner organization of the Poor People's Campaign, a national call for moral revival, I also host a national broadcast on Pacifica Radio called Sojourner Truth. Some of you might have heard of it. However, for the last a couple of years, I think, I had been promoting this film, The Power to Heal, during Fund Drive. And when I started the work with the Poor People's Campaign and convening the Policy and Education Working Group, I had no idea that the filmmaker was actually very, very active with us, Barbara Burney. She is with us today, and you will be hearing from her, Dr. Barbara Burney, following the film. But just to put the film in some context, one of the reasons I really love the film and think it's very appropriate for today is that in the Poor People's Campaign, we have the principle of not only fusion, coming together across race and across movements, but we also say, when we lift from the bottom, everyone rises. And I think this film is a great example of that, because it tells a little known story of the history of segregation in healthcare, which, as you could well imagine, was very, very difficult for those of us of African descent, other people of color, indigenous people who were at the receiving end of this kind of discrimination. But it shows how the civil rights movement, including the Black doctors, but not only people across race who supported the civil rights movement, came together to fight to end desegregation of hospitals, but in so doing, fighting and supporting Medicare. And then, as it turned out, Medicare was then the vehicle used to desegregate hospitals. You're going to be seeing a 30-minute version of the film. I'm sure after you see the 30-minute version, you're going to be very, very keen to see the whole thing. But it is a webinar. We wanted to have time for our panelists, so we won't be able to show the film in its entirety. But the 30-minute film is really exciting and a little known history that we all need to share. Dr. Barbara Burney, you'll be happy to know I'm already getting a request from Massachusetts, because they want to have access in the Poor People's Campaign to this film. So welcome everyone, and let us go now to the 30-minute version of our film.
And just a heads up for folks there that when streaming videos from Zoom, it's helpful if you have any other programs running on your computer that are using your internet, if you could close those just to make sure you can actually see the film and hear the film clearly.
Power to Heal, Medicare and the Civil Rights Revolution was made possible with the help of funding from the National Endowment for the Humanities, exploring the human endeavor. From the Arthur Vining Davis Foundations, dedicated to strengthening America's future through education. From the Robert Wood Johnson Foundation President's Grant Fund of the Princeton Area Community Foundation. From City University of New York. And from Hunter College, the Samuel Rubin Foundation, and the Yip Harburg Foundation.
For most of America's history, a system of racial segregation dictated every aspect of life. In no area was this more true than in healthcare.
When you think about the civil rights movement, you think about housing, public accommodations, and education. But I think the story hasn't been told often about what happened in terms of the institutions of medicine. So that's an unrevealed part of the history.
When I was 2 years old, I almost died of whooping cough. Being admitted to hospital was not even an issue. Hospitals were segregated, as were most hospitals in the South.
I couldn't lift my head, and I couldn't sit up. My uncle came and picked me up. He took me to the hospital. And the hospital said, we don't know what this is, but we're not going to take a black child that we don't know what it is.
Living was separate and unequal. So that made some individuals and communities sicker than others in the first place. But then once you got sicker, then access to the healthcare system was also unequal.
In the mid-1960s, while poor people of all races had little access to medical care, segregation made access even worse for people of color.
They didn't have to go to Africa or Latin America or Southeast Asia. We had a third world, including a third world for healthcare in Mississippi. People who lacked food and clothing and shelter, no protected water supplies, having to haul clean water from 5 or 10 miles away. Disease, malnutrition, suffering, and their combinations were rampant.
This was a population that had no medical care practically, and many who had never seen a physician before in their life. Women who had 8 children but had never seen a physician.
The system was a feudal system. You would get permission from the person that owned the plantation, and they would give you a note that you could go to the doctor.
These were reasons that life expectancy was so short for blacks in Mississippi, that infant mortality was so high.
In both the North and South, black babies died at twice the rate of white babies.
30 to 40% of live births was at home, sometimes not only at homes, but in the cotton field.
We didn't have a nursery, and we just took drawers out of cabinets and put babies in them, you know, and we could put those right by the mother's bed so that we didn't lose any babies or anything.
In our town, we could not use the hospital. It's called Parkview Hospital. Well, her final pregnancy, my mom was going to need a C-section. The baby was big. Dad went to the administrator at the hospital to say, could she please be delivered there? And they refused. She went into labor. They couldn't get her to the colored ward, so they delivered her at home. And my brother, I'm gonna have a hard time with this. My brother sustained a stroke because of it. That moment is why I'm a physician. It also was the defining moment for me about what disparities really were.
Disparities between black and white Americans were legally validated by an 1896 Supreme Court ruling that segregation was constitutional as long as the races were kept separate but equal. They were separate but never equal.
Everything was black and white. There was a black section and a white section. The cafeterias, the hospital waiting area, The rooms, the beds, and everything were in separate parts of the hospital.
Everything was inferior on the black side, from equipment to the blankets to the room to the painting. It was just clear.
Everyone was on one floor, no matter what you had, a baby, TB, or whatever.
Every time you went into a hospital that was segregated, it was saying to you that your life as a black person is not worth as much as a white life.
Yazoo City at that time was totally segregated. And one of my jobs as a young person was to answer the back door, which is where the colored office was. There would be someone who was so wounded, they would have to go to a hospital. So they would have to go to Jackson, which was 50 miles away. People routinely died on the trip to Jackson because there was no hospital in Yazoo City that would take blacks.
Segregation made it difficult even to get to the hospital. White-operated ambulances would not pick up black patients.
They had to use hearses. Hearses that were not in use were used as ambulances, and many black doctors reflected on the bitter irony of this because as the hearse plied from town to town like a Flying Dutchman, looking for a hospital, someone who would treat this patient, the patient often died in the back seat of the hearse. Many people assume that segregation was a phenomenon of the South, but it actually wasn't. It was very extended throughout the North as well.
Wherever you looked, you could see the reality of segregation, but there were no signs. Most hospitals in Chicago weren't admitting black patients at all. A few did admit some black patients, usually some segregated part of the hospital, never put in a double room with a white patient.
Emergency rooms would not admit black people if their quotas were filled, and therefore they were sent to county hospital with a note, no beds.
Even the wealthiest black patient had to go into the charity ward.
You could have $1,000 bills coming out of your ears, but if the 10% quota at the University of Chicago was filled, you went to county hospital. It was a mob. People were waiting and waiting and waiting. One night I had 20 admissions and 4 deaths of people I had not seen.
Southern states were determined to maintain segregation. They barred black students from attending state medical schools, but paid their out-of-state tuition in exchange for returning home to practice. Segregation also made it difficult for blacks to get training to become doctors and nurses, and once trained, to practice.
I came to Grady segregated. I went through Grady segregated. If I saw the class of 1964 white, I wouldn't recognize any of them. We didn't take any classes together.
We entered on one side of the hospital, and I cannot tell you which door the black students entered, but they didn't enter with us. We were not allowed to go to each other's dormitory. I'm afraid that I really didn't get to know any of the black class.
Many northern schools also refused to admit black students.
I was required to send a picture to Johns Hopkins. I had very good references from significant academic members of the Harvard community. But within 2 weeks, I got a rejection. And my conclusion was they saw my picture.
About 85% of all black physicians were educated at only 2 schools, Howard and Meharry. Faculty and students at these schools became the hub of medical civil rights activism. After graduation, it was very difficult for black doctors to get specialized residency training.
Most blacks, if they went into a residency, had to train in an all-black hospital such as Harlem or Providence in Chicago, Mercy Douglas, Philadelphia.
Black doctors could not get hospital privileges once they finished their training because they were barred from their local medical society. As a result, they could not admit their patients to the hospital or treat them there. These county medical societies were affiliates of the AMA, which refused to end these discriminatory practices.
American Medical Association had never been a friend of ours.
If you did not belong to the county medical society, you were denied admission. That was the first step of stopping you.
Some of the young docs now, They can't believe you mean to tell me you couldn't admit your patients to the hospital? You know? No, couldn't.
Barred from the AMA and refused admitting privileges, black doctors had to find sympathetic white doctors to admit their patients. Many carried a hospital in their black bags, delivering babies at home and performing surgery on kitchen tables. They continued to fight these injustices, forming their own medical society, the National Medical Association, or the NMA, to advocate for themselves and their patients.
A hospital is the workplace of doctors. Who determines who's going to be on the medical staff is the doctors themselves. All the doctors in these hospitals were white. They were admitting white patients, so that if you wanted to charge them with segregation, the doctors would say, well, we're practicing in this neighborhood, we serve our patients are white, this is our hospital. That's the essence of what you mean by institutional racism, right? It isn't something that you can pinpoint in terms of an action, it's built into the structure.
Congress passed the 1946 Hill-Burton Act, which provided for the construction and renovation of hospitals throughout the country.
It was a really large financial package that was going to transform the facilities of American hospitals. To get it through the Congress, the legislative process had to deal with the Southerners, and they insisted on a separate but equal clause would permit segregation in hospital facilities.
What it said was, go ahead, keep your segregated hospitals, and the federal government will support you.
Hill-Burton was the only piece of federal legislation passed in the 20th century that had separate but equal written into it.
Best characterized by Grady Hospital, the big public hospital in Atlanta, with one tower for whites and another tower for people of color.
The hospital was built like an H. The two front wings, the A and the B wings, were the white wings. The two in the back, the C and the D wings, were the wings. Everything was duplicated. There were two separate blood banks because it was a criminal offense to cross-transfuse blood.
The National Medical Association joined the fight for integrated health care, and leading the charge was Dr. Montague Cobb. Dr. Cobb invited the AMA and other white medical practitioners to an annual meeting on hospital integration. The goal was to develop a joint strategy to desegregate the hospitals, but the AMA never sent an official representative. The NMA, joined by Bob Smith and John Holloman, leaders of the newly formed Medical Committee for Civil Rights, challenged the AMA at their 1963 National Convention.
I accepted the role to go to Atlantic City and do something that no other physicians had done of record. That was the first time a group of physicians had taken direct action against AMA, demanding that they come out unequivocally against segregation and discrimination, and that the federal government would put some kind of enforcement clause into Hill-Burton hospitals. That was the beginning of some real pressure on the AMA.
Hospital desegregation was gaining more visibility, but the breakthrough they had all been fighting for was led by a dentist in North Carolina.
One civil rights activist and a dentist named George Simpkins contacted the Legal Defense Fund. It was not the first time. He'd been put in jail for trying to integrate a golf course, and he was a local gadfly, and he was a courageous man, and he said, I want to bring a lawsuit.
In the South, almost all of the cases, either against hospitals or schools, were brought by dentists. They were totally independent and therefore had a degree of freedom that even the black physicians in these communities did not have.
This was a chance to challenge the constitutionality of the separate but equal clause of Hill-Burton. Simpkins and a group of black doctors sued the hospitals. They lost in district court. It was a bitter defeat.
We lost it in the Middle District Court. Then we appealed it to the Fourth Circuit Court of Appeals.
When you challenge the constitutionality of a federal statute, you notify the government.
Robert Kennedy saw that notice and all kinds of bells and whistles went off for him. Because here he could enter into this decision as a friend, not of the defendants, but of the plaintiffs. That was almost unprecedented.
By throwing the full support of the Justice Department behind the plaintiffs in the Simpkins case, Attorney General Robert Kennedy reversed 100 years of federal collaboration with Jim Crow.
Discrimination must stop, not only because it is legally insupportable, economically wasteful, and socially destructive, but above all because it is morally wrong.
President Kennedy sent a telegram to Dr. Cobb confirming that he was finally joining the fight to end hospital segregation. On the 1st of November, 1963, the appeals courts ruled in Simpkins' favor. The separate but equal provision of Hill-Burton was declared unconstitutional. It was a huge victory, but the only way to enforce it would be to sue every segregated hospital in the country. New legislation was needed. President Kennedy proposed the Civil Rights Act, which, using language from the Simpkins decision, forbid discrimination in any entity receiving federal funds.
Next week, I shall ask the Congress of the United States to act, to make a commitment it has not fully made in this century to the proposition that race has no place in American life or law.
The prospect for moving civil rights forward looked promising. Less than a month after the Simpkins case was decided, John F. Kennedy was assassinated. Two of President Kennedy's goals were left unfinished: the Civil Rights Act and the Medical Care for the Aged, or Medicare. As Americans mourned the loss of President Kennedy, the country did not know if their new Southern president would pick up the mantle. Without presidential support, civil rights activists feared that progress towards equality and access to health care would be halted.
Let us carry forward the plans and programs of John Fitzgerald Kennedy with the earliest possible passage of the Civil Rights Bill for which he fought so long.
With the 1964 presidential election looming, President Johnson made the passage of Medicare a priority. This new legislation would provide an unexpected way to enforce civil rights in hospitals.
I am proposing that every person over 65 years of age be spared the darkness of sickness without hope.
These two major pieces of legislation giving health care access to the elderly and to the poor, they were opposed by the American Medical Association.
A new system of health care financing that is unwanted by many Americans, protested, and in my opinion, unnecessary.
Now the AMA doubled their efforts to raise a war chest and hired an actor named Ronald Reagan as their spokesman.
It's very easy to disguise a medical program as a humanitarian project. If this program will pass, behind it will come other federal programs that will invade every area of freedom as we have known it in this country.
Dr. Montague Cobb, now president of the National Medical Association, testified in favor of the bill.
The National Medical Association supported. First time a president had ever been to a meeting of the National Medical Association to speak, it was when he came to thank them for their support.
President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage. The Harry S. Truman...
The only representative of the medical profession invited to the signing of Medicare was Dr. Montague Cobb. He flew on Air Force One with the president. No representative from the AMA was invited.
$19 million Americans have enrolled so far in the Great Society's Medicare program.
Millions of elderly people in thousands of facilities and tens of thousands of physicians that had to be implemented within a year.
25% of the revenues of hospitals would be coming as a result of the Medicare program. How could the federal government begin the Medicare program and give federal funds to already discriminatory hospitals.
And that changed the game. This was a national program of great importance. Suddenly the healthcare facilities realized that they better get their act together if they wanted to receive funds under Medicare.
What civil rights activists had begun to discover is what we call the golden rule. Those that have the gold rule.
Secretary Gardner needed a team to inspect the hospitals resisting compliance. He sent out a call to every office in HEW asking for staff to work as inspectors. More than 700 people responded and joined this passionate bureaucratic army. The recruits included laboratory scientists, veterinarians, nurses, pharmacists, and managers of Social Security field offices. Few had any faintly relevant experience.
People had to volunteer to be on the front edge of what seemed to be an impossible task. They would be putting in hundreds of hours a week. There would be sleepless nights. There would be threats. Police departments that tried to harass them. They would deal with Klan members that would chase them. So the volunteers that they got were not typical civil servants. They were a group of really impassioned activists.
They had the orientation for these investigators at Center for Disease Control in Atlanta, Georgia.
Phyllis Cunningham, Jack Gogg, and I attended to orient the workers with regard to getting these facilities desegregated.
And they arranged for intensive training of the doctors and the Social Security administrative staff and the civil rights staff on what is it to desegregate a hospital.
So this was not the AMA. This was not the American Hospital Association telling them how to inspect hospitals. This was the civil rights movement that had, in fact, basically taken over.
We're here. We'd like to schedule a date when we can come by and talk to you and inspect the hospital to make sure that you're in compliance with Title VI.
Title VI of the 1964 Civil Rights Act stated that if you were a recipient of federal funds as a hospital or any entity, you are not allowed to discriminate on the basis of race.
We called it the DHEW shuffle. Department of Health at that time was a big boss. And that they'd shuffle beds around if they knew we were coming.
And there was a lot of switching of charts to show that they had an integrated facility. Signs were taken off doors, or pictures were hung over signs on doors that said colored, white, etc. But anyway, there was a lot of cover-up.
Federal inspectors contacted black hospital workers, maids, and civil rights activists to get the information to beat the HEW shuffle.
African-American women who worked as maids in the community picked up everything that was going on in the doctors' homes where they worked. In many instances, it was fired right back.
I didn't go to a single place where there wasn't a story of discrimination or deliberate exclusion, differential treatment.
Some of these white doctors who were heading segregated facilities tried to convince me in a patronizing way that the best healthcare system was one that was segregated.
One of the doctors said to me, if I admitted a nigger patient into my white cardiac ward, it would kill the white patient.
We had a meeting with the hospital administrator and the medical director, a fellow named Dr. Galloway, who I will never, ever forget. I could see Dr. Galloway's face getting red. And it got red and redder until it was really bright red. And when it really got bright red, he turned to me. I think he particularly resented me as a 22-year-old medical student. He wagged his finger. He said, boy, he said, let's get one thing straight. He said, no nigger doctor's going to look up a white woman's ass in this hospital.
The University of Mississippi Medical Center, Dr. Robert Marsden said, I know it's slow, but I want to tell you, as a measure of our good faith, that we have our first integrated ward. And here indeed was a 4-bed male ward, 2 African Americans, a white man, and a Native American. All 4 of them in their beds, all in the same room. So they had achieved their first step in integration with 4 people in a coma.
There were 3 or 4 instances to where I had to get out of town in a hurry. In Natchez, Mississippi, I finished a hospital and I just turned it down. But I said, you called me up here. when you know you're not in compliance with the act. And if I come back again and you're not in compliance with the act, you won't be in compliance forever. I'll do everything I can to see that you never see another federal nickel. I was leaving town and they shot my windshield out. They missed me, but they got the windshield.
As time ticked down, nobody was really sure what the hell was going to happen. The whole Medicare program would blow up potentially. And either Johnson would lose the Medicare program or he would lose the civil rights legislation that had been what he thought was his legacy.
We have some 100,000 people in Atlanta who are covered by Medicare, at least they think they're covered. But on July 1st, if in fact the hospitals are not in compliance, they'll find they won't have the benefits of Medicare.
Assuming that nothing changed, and it didn't look like anything was going to change, a large proportion of elderly beneficiaries of the Medicare program might be denied access to hospitals to receive care.
In a final attempt to bring more hospitals into compliance before the deadline, President Johnson called hospital administrators to the White House.
Now, we know there are going to be problems. One of them arises from compliance with the laws of the land, specifically the Civil Rights Act.
He said, and I want you to know, and he's pointing his glasses at people, we ain't gonna lock the barn door after the horse has been stolen. We're gonna desegregate the hospitals. And he put his glasses on, and he went on with his talk. They sure remember Lyndon Johnson's direct, clear statement of public policy. So desegregate the hospitals, and then you'll come in the program.
Overnight, thousands of hospitals desegregated. I mean, they made the decision that they weren't going to run the risk of losing that funding.
For all of those people that ended up being the volunteers, it was an amazing period. They really felt that the first time in their careers, they were really making a difference.
Johnson understood very well that the infusion of federal dollars in Medicare would be the hammer that we needed to integrate the health system.
It doesn't mean there's not tremendous systemic racism determining what hospital someone goes to or where they live or how they're treated. We shouldn't be naive. But that last step of the dignity and care at a hospital that's given to you regardless of your race or your gender or your orientation or any other of these characteristics, that is a human right, that's an American right, and we help to achieve it by hospital desegregation.
It's so critical that we continue on this road of universal access to care, but beyond that, of trying to create the kind of environment where everybody has the opportunity to be healthy. So the world has changed, and for the better, I think.
That's it.
What an excellent, important film. That was so great by filmmaker Barbara Burney. Our next phase of the presentation will be a panel discussion, actually, and we will have that in just 1 second. Before that, we're going to have instructions on how to donate to the work of California Poor People's Campaign.
Thank you very much, Jenna. My name is Faye Wilson Kennedy. I'm one of the co-chairs, and on behalf of the California Poor People's Campaign, first of all, I would like to say thank you to the filmmaker for making this powerful film. And then to all of you, we would like to encourage you to, one way you can support us, those of us who are part of the Poor People's Campaign, we're all volunteers out doing the work and engaging those folks within our particular communities. You could make a donation, a tax-deductible donation to our fiscal sponsor, Atina, and you could mail it to them. And hopefully Jim or Neil will drop that information in the chat. The address is 2010 Linden Avenue in Venice, California. And if you don't want to mail a check, you can also make a donation to the GoFundMe to help support the great work we do throughout California. So on behalf of the campaign, we'd like to say thank you for being here today, and particularly thank you for the filmmaker, and enjoy the rest of the webinar.
Thank you for that information, Faye. We're going to move into the panel discussion. Our first panelist is Sydney Ross Risden. She's an active member of the Los Angeles Poor People's Campaign and is a retired registered nurse. Welcome, Sydney.
Hi, everyone. I'm actually introducing our first panelist, who is the filmmaker from the fabulous film that we just saw, Dr. Barbara Burney. She's a distinguished scholar in public health, environmental justice, and the U.S. healthcare system. Her diverse experience in public health includes working as a frontline health worker in South Los Angeles, working for the County Department of Health. She went from there to Washington, D.C. to be a policy analyst with the United Mine Workers Health and Retirement Funds and in the Department of Health and Human Services. She was recruited to be director of an occupational health education center that provided education to women and minority workers. And after completing her doctorate, she became an associate professor at what is now the City University of New York School of Public Health, where she discovered the power of film and developed this dramatic documentary. She's also a member of the California Poor People's Campaign Policy and Education Working Group. So, Dr. Barbara Burney, over to you.
Thank you so much, Sydney. I'm Barbara Burney, as you just heard. I produced this film, and I'm sorry that at least on my version, it wasn't synced exactly, and it was a little bit jumpy, but I think that's what happens when you show the film on Zoom. What can I say? I want to welcome you all and thank you for coming. And I'm really glad that you could be here today. I hope you enjoyed the film. And I just wanted to tell you a little bit about how I came to make this film. A colleague of mine told me this story about how he had been sent to Marshall, Texas. And I didn't know this at the time, but he was actually in charge of the field operations for implementing Medicare. And he got sent to Marshall, Texas, because that was Lady Bird Johnson, the First Lady's hometown. And the president, Lyndon Johnson, did not want any hospitals in Texas, and especially not, excuse me, the one in Lady Bird's hometown, not to be desegregated. So he gets to Marshall and he gets followed from the airport by these guys in a pickup truck with a gun rack in the back, and he settles in and calls the hospital administrator and he says, "Hello, I'm Dr. Smith and I'm here to help you desegregate your hospital. Can we meet?" Well, the guy says to him, "No." I heard this. I was totally blown away to begin with. Anyway, then the hospital administrator called the president. And I don't know why he got through. I don't know whether it was because the president knew that Dick Smith was going to Marshall that day, or he knew the administrator because he was the administrator in Lady Bird's hometown. But anyway, he did get through and he said, "Mr. President, you mean for us to be desegregating our hospital?" And the president laughed And he said, why, yes, I did. And you know, Lady Bird and I are coming down for a wedding on Thursday. Maybe you could do it by then. Well, I heard this story and I was very blown away. First of all, I thought it was really amazing that I, who had been in civil rights like since high school and public health for decades, I didn't know this story. I didn't know. I mean, of course, I knew that healthcare, like everything else, was segregated, you know, until the mid 60s, but I didn't know the role of Medicare in desegregating hospitals. And I knew that this was a really important story and that a lot of us needed to learn about it. And that the way to do that was not in a journal article, but perhaps in a film. So that's how I came to make this film. I think that this is really important history for many of the reasons that Margaret also already mentioned. You know, it tells the story of how important the civil rights movement was in making both Medicare and the desegregation of hospitals possible. You know, the civil rights movement, after pushing so hard for Medicare, basically said to the administration, now that you have Medicare, you cannot give this money to any segregated hospital. You have to use this new legislation to desegregate the hospitals. And there was actually a lot of support even within the administration for this position. You know, that Secretary Gardner, who was the new Secretary of Health, Education, and Welfare, supported it. And that was it was very important that there was support all the way through the top and demands from the top all the way through the organization to make desegregation happen. And of course, you know, we can't forget that this was the height of the civil rights movement. So there were lots of people who were in the federal government, as well as grassroots activists and doctors and dentists and other healthcare professionals, people working, and also people working in hospitals who were committed to civil rights and to desegregation. And they all helped make this possible. In fact, the head of the National Medical Association, the organization of Black doctors and dentists, who was also at the time the head of the Medical Committee for Human Rights, formerly the Medical Committee for Civil Rights, was working one day a week for the Department of Health, Education, and Welfare, calling doctors and hospital workers in the South to get information for inspectors so that they would know what to look for when they went into hospitals. I think that this is really this is a really important film and moment in history because it shows that a social movement, the civil rights movement, can work with the government and can push the government and can get really important changes made and can get them made efficiently, effectively, and quickly. I think it's really important to remember that these hospitals were desegregated in a matter of months. And that, of course, they were desegregated partly as a consequence of the fact that there was a lot of money associated with Medicare. And as Sylvia Drew Ivy, who's in the film, I'm not sure if she's in the shortened version, but anyway, said, you know, green trumps black every time. So hospitals really could not survive without these Medicare funds. And because this was now in the administrative process and not the legal process, if the inspector said, you are not desegregated, you are not certified to get Medicare funds, you didn't get them unless the hospital went to court. And that was a very powerful incentive because that was going to take a long time. And if you were in fact segregated, then you were probably going to lose once you went to court. So the only way to get the Medicare money was to desegregate. And there was a willingness to do that, even if it was an unwilling willingness. I think it's also important to remember that this was a really important success, that desegregating hospitals changed people's lives. That we have to remember that what it means to get healthcare in a segregated system means that you have to trade your dignity, your humanity for your life and your health. And I think that that's really powerful, and it's why we have to figure out how we're going to get equity and healthcare for all today, how we're going to finish this struggle and get where we need to be, because the film reminds us that racism is a really fundamental problem in not just in healthcare, but in all aspects of American society, and that all these aspects of American society affect health. You know, what housing we have, what neighborhood we live in, what education we have available, what jobs we have available, all of those things affect health. And we have to be able to change those things. And policy, government policy, is going to change those things. And that's what we have to press for. And that's what we have to see. And that's what this film shows, is that the people who were engaged in the struggle were engaged in it for a very long time. They were always looking for the next opportunity to move these issues. And Medicare was one of them. And they seized it and they used it. And we have to do the same. You know, here we are in this moment where there's a real surge in attention to and the power of the Black Lives Movement. There's a real surge in interest in healthcare for all, and COVID has made it really, really obvious to everyone the impact of racism on our healthcare system. And I think that we have to use this opportunity. I mean, it's very sad, it's true, but it's still nevertheless an opportunity. And we have to push to move this struggle forward, to get much greater equity in healthcare and to get a universal healthcare system that covers everybody. And I think I'm going to stop there. And I just wanted to say I put my name and my email address in the chat. If you are interested in seeing the full film or hosting the full film, please be in touch with me. It's hospdeseg, HOSPDESEG @gmail.com. Again, hosp, HOSP, DSEG, DESEG, all one word, @gmail.com. And back to you, Sydney.
Thank you, Barbara, and thank you for the marvelous film and bringing it from there to the present. And I now want to introduce our next panelist. We're going to hear from Dr. Chandra Ford of the UCLA Center for the Study of Racism, Social Justice, and Health. She's also part of the National Poor People's Campaign Health Justice Advisory Committee, and she's lead editor of the book Racism: Science and Tools for the Public Health Professional. Welcome, Dr. Ford.
Thank you, Sydney. Let me just get my slides up. Okay. I also want to thank the California Poor People's Campaign for hosting such an important and I think timely screening and conversation. So, there we go. So I was asked to speak about healthcare inequities. And what I'll do is summarize some relevant COVID social and economic trends over the pandemic. I will turn to the wording of the Declaration of Independence also in order to call for a just model of healthcare for all, the only model that makes sense in light of these considerations. But first, like many of you, I conduct my work in Southern California on lands inhabited by and cared for by the Gabrielino Tonga peoples. And I believe that's important because, as with this film, we see that we cannot do the work of equity in the present without acknowledging and seeing the ways that historically inequities have impacted us. So as you all know, there have been nearly 600,000 COVID deaths among US residents since January of last year. Put differently, the nation has lost about 1.6% of its population over the last year due to COVID. And for more than every 600 and some odd US residents, one person has died of COVID. But as disturbing as these numbers are, they mask stark racial and ethnic disparities, many of which are rooted in historical racism. So this chart shows the number of people by race and ethnicity for every 100,000 people of that race and ethnicity. And what we see is that a disproportionate burden occurs among Black, Indigenous, and people of color communities. 15% of COVID deaths occur among African Americans and Black people. And this chart also shows that how important it is to capture some groups in disaggregated ways. So in particular, to separate out Asian from Pacific Islander and not just collapse them as Asian and Pacific Islander. When we do that, we see that while 87 per 100,000 Asians and Asian Americans have, experienced death or die from COVID, 132 Native Hawaiians and Pacific Islanders do. As of January of this year, more than 10 million people are unemployed, 3.5 million of them permanently unemployed. And it's difficult to tell exactly how many people have lost in healthcare coverage during this period. The census says about 8.8%, and that is from 2019. The Kaiser Family Foundation data suggests that this has remained relatively stable over the pandemic, even though the need for healthcare, COVID-related healthcare, has increased over this time. It's also not entirely clear how healthcare insurers have been impacted by the pandemic, both in terms of gains and losses. As this pie chart shows, half of all spending for healthcare goes to pay providers and hospitals, only about 10% for prescription drugs. As of the second quarter of 2020, 3 health insurers, United Health Group, Anthem, and Humana, had netted 6.6 billion, 2.3 billion, and $1.8 billion respectively, all substantial increases over the same quarter in the previous year. So we are in the early 21st century, and in this context, healthcare is a critical resource that all people must rely on to attain health and to maintain health. And we would not be in the state that we're in now in terms of having the resources, having the medical advancements of healthcare and medicine, were it not for the sacrifices our communities have made over many generations, many of those sacrifices involuntary. So if we assert that healthcare is a right, then that means that what it is healthcare produces, health, must also be a right. For me, the fundamental issue is whether healthcare is an industry or it's merely a sector that affords us certain rights. And if it's an industry, its primary aim is to generate profit, and patients are merely one means of doing so. If it is a right, however, its primary focus is to promote health and prevent disease, and it works in the service of the people. I believe the Declaration of Independence actually gives us insights here in terms of the spirit of the nation that the framers had in mind, in stating that, quote, all men are created equal and have certain unalienable rights. Among these are life, here then I think specifically of health, liberty, and the pursuit of happiness. And it goes on to say that to secure these rights, governments are instituted, deriving their powers from the consent of the governed, unquote. And in this, the framers are conveying that the ability to live a fulfilling life is a right that no government can obstruct. The nature of the current system and the complicity of the government in sustaining it run counter to this declaration. And they contribute to the misperception that the US has the best healthcare system in the world. That mythology itself serves as an impediment to achieving health equity, in part because it belies the need, it suggests we do not actually need to focus on addressing health inequity. Let me conclude by saying this is an optimal time to advance these issues. The CDC, Centers for Disease Control and Prevention, recently declared racism a public health problem. Also, there are a number of books, several books that can be used literally as hand tools for those of us who are interested in achieving racism-related racial health equity, as well as health equity overall. And so I think I want to encourage us to push now for the only model that makes sense, healthcare for all. Thank you.
Thank you, Dr. Chandra Ford at my alma mater, UCLA. That was an excellent presentation. Next, we're going to hear from Virginia Hollins Davidson, who will be presenting a song for us.
Fight on just a little while longer. Fight on just a little while longer. Fight on just a little while longer. I know justice is coming soon. Hold on just a little while longer. Hold on just a little while longer. Hold on just a little while longer. I know justice is coming soon.
Wow, wow, what a song, Virginia. You just inspire us each time that we have you here as a singer. My goodness.
You're on mute, Rose.
I was saying, what a powerful song. Virginia, you definitely put a spark on us every time that you come onto our webinars. But now I am actually now going to present to you a member of SEIU 2015, California long-term care worker, She is the voice of many healthcare workers in our state. They are the ones that provide quality long-term care for our seniors and our disabled. I am honored to present to you my union sister, Wendy Whitaker.
Hey, good afternoon, everyone. My name is Wendy Whitaker. I've been a home care provider for more than 12 years. And in the course of being a home care provider, I had to give up my job. I had a good paying job as a teacher, and I'm now making a little over minimum wage. I cannot afford health care. It has not even been offered to me. When I researched our system for affordable health care, the least expensive plan that I was offered, because I am a type 1 diabetic, was $2,300 a month. My insulin, one bottle, lasts 30 days, is $372 a bottle. And without affordable health care for myself, because I'm in a position that I must care for somebody else, it was not a choice that I made to become a healthcare provider. It was out of necessity. And I'm caring for somebody that is in a worse situation than myself. And not being able to have health care is ridiculous. I live in the most financially fluent country in the world, and I am not offered health care. How sad is that? It is so disturbing to me to be in a situation where I could go to another country and get health care. And then in my prosperous country, it's $2,300 a month, and I make a little bit over minimum wage. We need to have health care for everyone, and it needs to be affordable. And it's not something that is not realistic. It is not something that cannot be achieved. And I find it so disturbing that we as healthcare workers are put in this situation. I have not been offered home care, insurance through my job. And with that being said, there are hundreds and hundreds of providers that I talk to on a regular basis that are fighting for coverage of some sort. If I were to be diagnosed with COVID, who's going to pay for that? It's a shame. And I'm just appalled at what my country has to offer for me. Thank you.
Hello, everyone.
Hi.
My name is Nancy Berlin. I live in Los Angeles, and I'm a member of the State Coordinating Committee for the California Poor People's Campaign. And I'm pleased to introduce our next speaker, Jacqueline Johnson. Jackie and I are both part of Alexandria House, which is a transitional residence, house of hospitality, and supportive community for women and children. And she was instrumental in our caring and us being able to carry out our Get Out the Vote campaign there last fall. Jackie is also an active member of Global Women's Strike and the Poor People's Campaign. And in fact, she was part of our California delegation to the Poor People's Campaign Moral Congress that was in Washington, D.C. in June 2019. One of the things I love about Jackie is she is not afraid to speak up. And she is here today to tell us her experiences with the U.S. healthcare system. So welcome, Jackie.
Okay, welcome. Jackie is like, where is she? Okay, hi, Nancy. I totally apologize because I was on until you said my name. So bear with me. Can everybody hear me, even if you can't see me?
Yes, we can hear you.
Okay, I'm going to try to get back on because I really thought I should be seen, but
We can see you, Jackie.
I'm sorry.
We can see you.
Oh, because I can't see you. Okay, hi. Then, hello, everybody. Thank you for giving me the opportunity to talk about the disparities and impact of the healthcare system. My name is Jacqueline Johnson, and I do live in Los Angeles, which is a terribly expensive place to claim residency. I live in an affordable housing building, but half of my income really is going toward rent and utilities and everything. So I don't have a lot left for such things as, in quote, medical costs. About 15 years ago, I was diagnosed with thyroid cancer. And as scary as that is, the help of it was that I did have insurance, I did have coverage, I got through all of that. But when I lost my coverage, I applied for Medicare, and I found two things. One is that you have to be able to pay your 20% of your medical costs, whether it's a hospital visit, a doctor's visit, lab test, medication, or whatever. You have to be able to pay your 20%. And number two, you have to find somebody, a doctor's office, a clinic, or whatever, that's willing to take and accept your Medicare. This was an impossibility that I was really to the point of like, why bother? And thanks to a friend who had a board that had doctors and people on it, I was able to get a doctor's visit, a prescription, and help that I needed. But now I'm old enough, and I guess uh, poor enough that I do qualify for Medicaid and Medicare, which is good, except in October, they totally took $300 a month out of my already not sufficient income because Social Security, whatever. So I still have to pay out of pocket for prescriptions. I'm just at a point where I think it was Miss Mo that said, if you're mad enough or tired enough, I don't know about being mad enough, but I sure in the hell am tired enough of having to worry about what did I do wrong this time that they may decline or deny benefits next time. So I just want to say that it's caused more problems than it's resolved. And one of the things that I want to bring up is that it's almost as if the system is designed to take away and not give back or reach out and help. And Dr. Burney was talking about what we need to do. I don't want to sit here and talk about what America has got, how America's the wealthiest country and what America's got. America also has 140 billion, like Gates billions, people who are doing without, who are hungry, who are homeless, who are hiding and hurting. Okay, so what America's got ain't putting nothing in my pot. So we need to get from impacting what's wrong to the bottom line, which is resolving and asking for and demanding and receiving what it is we need, because this is broken. And the people that I know, my family, especially women, when something is broken, they know who to call. They know how to get things fixed. Well, our healthcare system is broken, and we need to know who to call and what we want them to do to fix it. So thank you for the opportunity to talk about my problems and how I've been impacted because of this discrimination and the disparities. But more so, I want to be on that plane that's going to take us to getting to bottom line with resolutions and refunds or resources or whatever it takes. So thank all of you for what you do and what we've been through, but we've got to step up, unpack the impact and move on. So thank you.
Thank you, Jackie, for that testimony. We really appreciate your personal story. Next, we're just going to segue back into how you can help support the work of the Poor People's Campaign, the California campaign, and some of the work that we do. So I believe Peg is going to give us more information.
Hi, I'm Peg Miller, and I'm part of the California Poor People's Campaign. I live in the East Bay. So how you can donate to the California Poor People's Campaign, you can make tax-deductible checks made out to our fiscal sponsor, ETINA, at 2010 Linden Avenue in Venice, California. And you will see that information in the chat. There's also a website that you can go to donate. So we appreciate you being here today, and we appreciate your support. Thanks.
Thank you, Peg. Next, we're going to hear from Shannon Rivers, who is going to give us a little bit of personal testimony about the effects on the Indigenous community.
Thank you, Dina. My name is Shannon Rivers. I hope you all can hear me pretty well. I'm as close as I can to my mic. So I want to talk a little bit about Indigenous peoples, not only in California, Los Angeles, but statewide and nationwide. Again, my name is Shannon Rivers. I'm part of the Indigenous Peoples Collective, a partnership with the Poor People's Campaign here in California. I'm right now in San Jose in the East Bay area in Ohlone territory. So in Los Angeles County alone, there are 175,000 Native Americans. We know that the population of indigenous peoples is about 1 million people, Mixtecs and Zopotecs, who are indigenous peoples from the south of the border. So I want to give you a little bit of history of the relationship between the Indian Health Services and the United States government. Indian Health Services, of course, is a branch of the federal government that is to analyze and assess the needs of medical and healthcare among American Indians. There are 577 federally recognized tribes and probably about 109 in California that are either federally or non-federally recognized. So that's really important. In the states with Indian Healthcare Service hospitals, the death rates of preventable diseases like alcohol-related illnesses, diabetes, and liver disease are 3 to 5 times higher for Native Americans who largely rely on hospitals, those Indian Health Services that I mentioned, than any other races combined. Federal government spending on healthcare for Native American lags that for almost any other population in the United States. In 2016, the federal government spent about $8,000 per capita on healthcare for federal inmates. These are inmates, and $2,000 per patient with the Indian Health Services. In 2017, Indian Health Services spent about $3,000 per capita, according to a report by the National Congress of the American Indians. By comparison, Medicare spent about $12,000 per patient. That year, Medicare spent $7,000 per patient. The report said, right? In South Dakota, some of the poorest populations of Native people, Arizona. We talk about the coronavirus and the impact on indigenous peoples. We know that the Navajo Nation, for example, in Arizona, had almost 3 to 4 times the death rate of New York per capita.